So this is the second revision class. So now you will be able to tell, okay, how to take a proper history. So tell, how will you take a proper history? Introduce yourself.
Hello, I am Ankita Sinha and I am a medical student.
Then
As for the particulars of the patient, what is your name? What is your age? What's the address, religion, gender, father's name?
and
Marital status.
yes, then occupation, then nationality. Okay. So these are the things in particulars of the patient. Then
Chief complaint.
chief complaint. So how will you write a chief complaint?
What are the problems he is coming from? What the problems he is facing?
That means what are the major problems which let him come to the hospital or to the chamber of the doctor. Okay. So we might have 10 problems, okay, but for all 10 problems we don't go to the physician. Okay, there might be some few problems for which I am unable to bear it. Okay, it is too much. Okay, for those problems I need to go to and consult to the doctor. Okay, so how will you write the chief complaint? Suppose he is having complaints of coughing last 6 days, then shortness of breath last 4 days, and chest pain for last 7 days. So how will you write?
Chronological order.
How? Chronological order means?
By time.
Yes. So the first complaint which started. So the chest pain is the first complaint. So yes, chest pain for last 7 days. Then coughing for last 5 days. Then
Shortness of breath for
last 4 days. Okay. So this is the chief complaint. You are getting?
Yes.
Okay. So after that,
history of present.
yes, history of present illness. So what will you write in that? Okay. So how will you elaborate?
So, for example, chest pain, onset of chest pain, severity, exacerbation, and the time.
So fast.
Side.
No. Before going into that complaint, first what will you write? You will write that I am a medical student. Today I will be taking a case of this patient. Okay. And he was apparently well 7 days back or not. Okay. Then you will start elaborating the complaints. Okay. If he was alright 7 days back, then you have to write he was alright. Okay. Then how will you describe the pain? One mnemonic. Okay. S for? Okay. Site means?
The
Location of the pain. Okay. So from where it started? Suppose it started from the left side or the right side of the chest. Okay. Then this is the site. Then onset. Onset means?
how many days I will start?
Yes. Then character means? Type of pain. What are the types of pain? Stabbing, then dull aching, then pain sensation, then radiation. Radiation means where the pain is radiating. Right side, left side, towards the neck. Then associating factors means yes, like nausea, vomiting, headache, okay, vertigo, these things. Then A for associative factors. Then T for time or duration. Okay, time or duration. What you will write? Means for how many days. Okay. Then E for exacerbation. Okay. So what are the aggravating and the relieving factors? Okay. So what will you ask in aggravating and relieving?
It is increasing when the pain is increasing. It is climbing stairs or
Walking, working. Okay, when it is getting increased. And relieving में
How does it go down?
like sitting or taking rest, lying down after taking medication. Okay, then severity में
0 to 10.
0 for 0 for no pain and 10 for
Unbearable.
unbearable. Okay, so according to that you have to score the pain. Okay, then what is the next complaint? Coughing. So how will you describe coughing? Acute, then subacute and chronic. Acute means less than 3 weeks. So this coughing is acute. Okay, so subacute means 3 to 8 weeks and chronic more than 8 weeks. Okay, then dry or productive. Okay, in productive the sputum will come. So what will ask for sputum? First is the consistency. Okay, then consistency means it is jelly like, slimy, okay, purulent or mucopurulent in nature. Then color like greenish, then yellowish, then blackish, then
Pink color.
pinkish. Okay, then blood stain, then whitish. Okay, then odor. Then in water, what will you ask? Whether it is foul smelling or not. Okay, then whether it is associated with blood or not. Okay, blood mixed sputum or not. What it is known as? Hemoptysis. Okay. Then you have to ask any variation is there or not. Whether in the daytime he is having more, the night time it is more. Okay, when it is getting increased, when it is getting decreased, any particular time is there or not. Then what are the relieving and aggravating factors you have to ask. Okay. Then what is the next complaint? Shortness of breath. How will you describe shortness of breath?
By doing anything?
Okay, is there any variation between the daytime and the night? Okay, when it is getting increased, when it is getting decreased. Okay, aggravating and the relieving factors. Okay, then what is the next point? History of past illness. You also tell some points. After history of present illness, you are present or absent. Then tell history of past illness. Okay, so what will you ask in past illness?
These problems you had faced before also.
Similar symptoms. Okay, then before surgical.
Faced systematic diseases.
Yeah, so whether he was diagnosed from any disease, okay, he suffered from, whether he has taken any medications, okay, any disease for which he was admitted or hospitalized, okay, then any operation, surgery history, okay, this will be in past history. Then drug history, okay, what in okay, suppose he is suffering from any disease, okay, if he has any disease, whether he is taking medication regularly or not, okay, how many times he is taking, since how many days he has been diagnosed, okay, then allergy history also you have to ask here, okay, whether he is allergic to any drug or not. Then family history, okay, family history.
One of his family.
Okay, any disease they are suffering from, okay, so since this is a respiratory class, so you will be more focused to the respiratory symptoms, okay, like asthma, COPD, okay, then TB, tuberculosis, okay, then okay, occupational history. Before occupational history, personal history. So how will you take a personal history? This is very interesting, okay, many things are there, but it is also easy if you know it.
First, we have to analyze by looking first.
The diet.
First is the
Physique. First, physique.
it will come step by step. What is the first thing? First is the appetite. Yeah, I told na. First was the appetite when you will wake up in the morning. First thing when you will be taking shower and all everything, brushing your teeth. That time first thing you will have an appetite. Okay, you feel hungry. So whether his appetite is good or not, whether he is more hunger, okay, whether his appetite is less or he is deprived of any appetite. Okay, he is not feeling any hunger. Okay, then after appetite, then he will take his breakfast. So about his dietary history. Okay, what will you ask in diet? He is vegetarian, non-vegetarian. Then then whether he is like having junk foods. Okay, these things, street foods. Okay, these all will come in dietary habits. Okay, if he is a non-vegetarian, okay, you have to ask what are the particular things he is taking, and if he is a non-vegetarian, you have to particularly ask what are the things he is taking in his non-veg diet. Okay, sometimes he might be a vegetarian, he might be a non-vegetarian, he might complete his overall diet. Okay, but sometimes he won't be able to complete because he don't have the knowledge. Okay, proper knowledge. You have to ask this. Then after getting food, he will get energetic. Okay, he will take his calories and all, and then he will work. So you have to ask about his physical activity. Okay, so in physical activity, what you will ask? You can understand me?
Yes, sir. He's doing exercise.
Exercise. What type of exercise? If he is doing any physical activity like cycling, walking, anything. Okay, running. Okay, weightlifting, anything. What he is doing? Okay, how many hours he is doing? Okay, you have to elaborate that part. Then, yeah? Okay. Defecation. Okay. Before defecation.
If he is feeling exercise, if he is feeling restless.
No, this is okay. That much is okay.
After how much time he is having shortness of breath?
Anything? So after taking food, there is a normal daily allowance. Okay, like for females the calorie intake is how much? Like 1800. For males it is like 2000 or 2400. Okay, so whether he is calorie deficit or whether his calorie intake is good or he is taking over. Okay, so how will you measure anything?
By knowing his diet.
So you have taken his diet history, you have taken his physical activity also. So on the basis of that, anything, whether he is obese, underweight, yes, BMI. So now BMI. So this is the thing you have to ask. Okay, without BMI you cannot tell him that whether he is normal or obese or underweight. So what is the normal BMI?
24.
18.8 to 24 point. Okay. 18.7 to 24.5. Okay, so above it is obese and below it is underweight. Okay, then sleep cycle. So after BMI you have to ask about his psychology also. Okay, like whether he is an aggressive person, okay, whether he is a calm person. Okay, you have to ask whether there is mood fluctuation in any part of the day or night, whether he is getting irritated most of the time, or in like regular conversation he is getting irritated or not. Okay, this will also come in personal history. Then the evening has come. Okay, then the digested food will be defecated. Okay, and the water intake, whatever he has taken, okay, that also will be excreted. So about his bowel and bladder habits. So how will you take it? Like defecation. Okay, in defecation how will you ask? Okay, type of stool. Okay, whether it is dry or semi-solid or loose. Okay, then color of the stool. Okay, then okay, smell. Then whether it's foul smelling or not. Okay, then before that, like whether any association is there, okay, with the stool, whether it is mucus mixed stool or blood mixed stool, okay. Then any difficulty in passing stool, okay, then we will go for urination or micturition. So what will you ask? Okay, first you will ask that whether the micturition has how many times he is passing urine, okay, whether it's increased, okay, decreased, or he is unable to pass, okay. Then color will come, okay, whether it is yellowish, okay, or lemon color, okay. Then any like blood in urine, okay, then pass, okay, discharge there or not, then okay, smell of the urine, okay, then
Painful maturation.
yes, painful or burning sensation, okay. Then okay, then after finishing it, okay, he will go to sleep. So you have to ask the sleep cycle. How will you take the sleep cycle? So first you will ask how many hours he is sleeping, okay. Normally it is 8 hours, okay. Then yeah, so whether it's increased or decreased or is deprived of sleep, okay. Then
Difficulty in focus.
okay, yeah, this I have told. Then another thing is there, that is the anything in personal left about his addiction.
Yes.
Addiction,
Alcohol.
yes, whether he is a smoker, okay. So if he is a smoker, then how will you take the smoking history?
How many? For how many time? How much time is?
Okay, for how long he's been a smoker, okay. Then
How much he
If
smokes?
there are any additional things he's doing.
then you will ask how many sticks he is taking per day, okay. Then yes, any additional
Substance.
substance abuse is there or not, okay, like cocaine, then heroin, then cannabis, okay. Then alcohol history, how will you ask?
How much time?
How much amount is?
How long?
Yeah, for how long is, if he is an alcohol, for how long he is alcoholic, then how many ml he is taking per day, okay. If he takes per day, okay, if he takes weekly, then how many ml he is taking weekly, okay. Then if he is an IV drug user, okay, that also you have to ask, okay, or any tablets he is taking like yaba tablets, okay, about his addiction, okay. Then personal history finish, okay. So this much is okay if you can remember, okay. Then
Socioeconomic.
before socioeconomic, social history. So what will you take?
His relation with neighbors.
His
Relation with neighbors.
yes, his relation with neighbors. Then travel history. Then pet history, okay, exposed to any wild animals or not, okay. Then okay, you can go to socioeconomic. Last is the socioeconomic. So what will you take in socioeconomic?
Job history. Job profile. How much does he earn?
Yes.
What is situation of his family?
So socioeconomic means how much he is earning, okay. You have to write in per month. Then according to that you have to classify it low, middle or high class, okay. Then you have to write about his expenditure also, okay, how much he is expenses, how much he is saving. Anything? Occupation history, okay. Occupation history, what will you ask?
What he does?
Okay, how much hours he is working, okay. Then okay, this much is okay for history. Then we will go for GP, okay. In GP what will you do?
General appearance.
General appearance, okay. First is the build, okay, whether he is thin build, he is obese, okay. Then
It's coming with concept.
Yes, you have to observe him. Then, okay. So, what are the things what are the signs you will see for respiratory case? Pallor. Okay. So, what are the site for pallor? Lower. Palpable conjunctiva. Okay. Which is the show me? Which is the lower palpable conjunctiva? Yes. So you have to tell the patient to look up in a bright natural light. Okay. Then no, for sides, more sides. Yes, palms. Okay. The creases you have to compare with the your hand. Okay. Then ventral surface. So which is the ventral surface of the tongue? Okay. So it will be pale in color. Pale. Okay. Then you can see in the nails also. Okay. Then yellow. So the next sign is cyanosis. So cyanosis are of two types. One is the peripheral and the one is the central. So for periphery, where we look? Fingertips. Okay, this will be bluish discoloration. Okay, and in toes, lower limbs. Okay. Then what for central cyanosis? Tip of nose. Then base of the tongue. Which is the base of the tongue? This is the base.
Oh, sorry, base of the tongue.
So this is the base of the tongue. Then only two sides. Earlobes. Which is the earlobes? No. Yes, this is the earlobes. Then any more side left? Lips. Okay. So what is the next sign? Okay, lymphadenopathy. Okay. So how will you check for lymphadenopathy? Show me. Okay. Then mental is here. Okay. And maxillary is this one. Okay. Mental is here. Okay. This is the mental now. This is the mental. This is the maxillary bone. Okay. No. Pre? Yes. Then? Okay. Axillary. Axillary also. Okay. You understood? Show me. Dikhao. First of all, you have to be in the back of the patient. Okay. Always stand in the back side of the patient. Then which is the supraclavicular? Then preauricular. This is the auricle. So which is pre? Pre means yes, front. Then postauricular. Piche. Yeah. Niche. Yeah. Postauricular. Then cervical. Spine. Yes, is side pain. You have to palpate with both the hands. Okay. You understood? Rohit?
Yes.
Okay. This is lymphadenopathy. Okay. You have to also palpate about his axillary also. Okay. Then cyanosis again. Clubbing. So how will you check clubbing? So what is that?
Diamond shape.
Okay. So normally it is diamond shaped. Okay. It is 160 degree. This sign is known as Shamroth sign. Okay. So in clubbing what happens? There is bulbous enlargement of the nail beds. Okay. so the angle will be obliterated, so it will be more than 160. So this diamond shaped will be not seen. Okay, then any test, fluctuation test. So show me how will you do the test. Then
We lock the phalanges with
which phalanx?
this.
There. So there are 3 phalanx. Phalanx. The phalanges. Okay. This is the which phalanx? This is which phalanx?
This.
Okay. So what are the 3 phalanx? Proximal, middle and distal. Yes. So only that phalanx we will block. So how will you block? Yes, we will use our index and our ring finger.
This one we will pressure.
Not in the joint but in the base. Okay, this is the base of the nail.
If
So?
you feel a pressure, there is clubbing.
Or fluctuation. Okay, so if there is fluctuation, that means fluctuation test positive. So the patient is having clubbing. It is seen in initial stages. Okay, in initial stages of clubbing. Okay, not on the later stages when there is more growth. Okay, when it will be extended in the wrist. That time it won't be seen. Okay, then jugular venous pressure. Okay, have you got the term? Okay, how do you do it?
So you have to see the national venous pressure. You have to look at the sternal angle, and from there, joining these 2 points.
How will you show on him? Let me see how much you could retain. Before that. Okay, consent taken. After that, so you have to tell the patient to lie down. Okay, so can you lie down?
Yes.
Okay. So he has lied down. Now what is your next thing? Okay. So you have to move him at an angle of 45 degree. Okay, you have to elevate his upper limb or the head. Okay, so suppose you have elevated at the 45 angle, then
This further just for example, and there is a maximum venous pulsation. So this is the height of the measure.
so we'll take the measuring scale. Okay, when we'll elevate his head upwards, the pressure will be more. Okay, in the veins. Okay, which vein?
External.
No. Yes. So first of all, you need to differentiate between the 2 veins. Okay. So how will you differentiate between the 2 veins?
Their orientation.
Okay. First of all, you need to differentiate between an artery and a vein. How will you differentiate?
Arteries and pulses.
Pulsable. Then, and veins are not pulsation, not palpable. Okay. So suppose this artery is which artery? Radial artery. So you can feel the pulse. So vein, it is, you cannot feel the pulse. Okay, it will be like a wave. Okay, it will be coming and going, coming and going. Okay, so how will you identify it is an internal or external?
Orientation of the veins.
Like how? So there is one muscle, na? What is this muscle? Sternocleidomastoid muscle. So the vein which is more prominent, okay, and centrally placed middle to the sternocleidomastoid muscle, it is the internal jugular vein. Okay, which is lateral and more thinner or like a curve. Okay, it is going. Okay, it is external jugular vein. Okay, so you have to see for in the internal jugular vein. Always remember, we have to see the internal jugular vein, not the external. Okay, then you have find it out. Okay, you have raised him at an angle, so the pressure will get more there. Okay, now you will take a measuring scale. Okay, then with the help of the measuring scale, what will do?
Measure the height.
How will you measure? Can you open your buttons?
Yes.
first of all we need to find out the vein. Okay, suppose in his right side it is visible. Okay, it should be visible with the naked eye. Okay, then we'll slightly turn his face towards the opposite side. Okay, then we'll find out the jugular notch, then the sternal angle. Okay, then the highest pulsation, suppose it is here. Okay, so we will place, so now it is like a bit inclined. Okay, it is not straight now, it should be horizontal. Okay, this measurement, okay, this scale. So suppose if this is the maximum pulsation here visible, okay, the vein is visible here, so we'll just place the pen in horizontal direction, in straight. Okay, so when we will be elevating him, so it will get a bit more like this and a bit more curved. Okay, then it will come in proper position. Okay, so the maximum height we will measure from the sternal angle. Okay, so what is the normal? 7 to 8. Okay, so we have to measure the total height. Okay, but we can only measure the part which is above the sternum. Okay, so normally it is 2 to 3. Okay, if it is more than that, then we will say that it is the jugular venous pressure is raised. Okay, so how will you calculate?
So the height of the internal jugular vein from the right atrium is normally
5 centimeters.
And is it
The normal height from the right atrium to the sternal angle, it is 5 centimeters, and the height from the sternal angle to the measured, okay, the highest it is 2 to 3. So we have to add it. So 5 plus 2 or 3 means 7 to 8. Okay, so if it is more than that, it is raised. Okay, understood? So the unit will be in, not in centimeters, not in mm, it will be in centimeters of water, but we have to convert it in mmHg. Okay, so the calculation is 1.36 mm, a centimeter of water is equals to 1 mm of 1 mm Hg. Okay, the calculation. Okay, so it comes roughly around 6. Okay, 8 or 9 centimeters of water is equivalent to 6 mm of Hg. Easy? Can you tell me? Repeat it once more. You lie down. You are the patient.
So only the procedure.
देखा एक बार procedure, the whole thing which I said.
This is the suprasternal notch. Suprasternal notch. Suppose, for example, this is the highest venous pulsation. Suppose we have to, from the sternal angle, to measure the height.
It has to be horizontal. Okay. So after that,
To calculate the height of this measuring scale.
how will you calculate? The distance between the right atrium to the sternum, it is sternal angle, it is 5 centimeters. So the maximum height which you got, you have to add it. So what was the height? Around 2 to 3 centimeters you got. Okay, then it is 7 to 8. What will be the unit? Centimeters water. Okay, of water. So you have to again convert it. So how will you convert?
Into
1.36. 1.36 centimeters of water equals to 1 mm of mercury. So roughly it comes around, if it is like 8 or 9 centimeters of water, it is equivalent to 6 mm of Hg. Easy? Okay. So when you will be going to clinics, that time you have to apply this knowledge. Okay. Okay, normally it is not written here in your clinical books. Okay, it is not there, but in higher classes you will get it. Okay, in clinics. Then after jugular venous pressure, anything more in GP? Flapping tremors. Okay, do you know flapping tremors? You? Okay, what is flapping tremors? This is the patient. What will be the position? So we have to tell the patient to straight his hands, okay, or fix his hands straight like this. Then extend or flex it, okay, towards himself. Then Normal.
It comes like
Flaps. Okay, how it looks like? Show in his hand. It is stiff. It will be like moving like this. Okay, it's flaps. So it means patient is having flapping tremors. It is seen in retention of CO2. Okay, so all these things are related to respiratory case. Okay, the next sign. Okay, you can relax. So the next sign, anything? Nicotine stain. Do you know nicotine stain, sir?
Yes.
So what is that nicotine stain?
On lips or in hand.
So yes. So the two fingers which you will be using to hold the stick, okay, there stain will be present, okay, for nicotine, okay. So and his lips and teeth, okay. Any more point? So we have to also hear about his voice, okay, whether there is hoarseness of voice, okay, whether he can speak properly or not, okay, whether he is unable to speak properly, okay, then yes, any sound, okay. Suppose he is having shortness of breath, okay, that time any additional sound we can hear from him or not, okay. Then this much, okay. You want to add anything? You? No. Okay. Then system examination. So what is the first point? Consent. So how do you take his consent? I can't hear. Do you allow me to? Yeah? No, you cannot ask this. Yes. Okay. You have to ask. Will you allow me for your examination? Okay. Then if he says yes, then you will proceed. Okay. So, what is the first thing? Inspection. Inspection. What will you see? Position of the trachea. Okay. So, in position of trachea, what will you see? Centrally placed or slight deviated towards the right. So it is normal. Then
Shape and size.
shape and size. So shape and size. What is the normal shape of the chest? Bilateral elliptical. Can you name some abnormal deformities of chest?
Pigeon chest.
Pigeon shape or pectus? Yes, pectus carinatum. Okay, so it is seen in rickets. Any other?
Rate of disease.
No. Deformities of chest. Barrel shape it in. So what is the normal shape or the size? What is that? Yes, you're saying? So one index is there, it is known as Hutchinson index. Okay, so the lateral distance, okay, or the transverse distance is to anterior posterior, it is 7:5. So the transverse distance is more compared to the anterior. Okay, so in barrel shaped what happens?
Circular.
In pigeon shaped what happens? Anterior posterior diameter is increased. Okay, in barrel shaped,
Hole.
yeah, the whole diameter, okay, the anterior posterior as well as the transverse diameter, it is increased, okay. Then it becomes like the shape of a barrel. It happens in chronic smokers, okay, or COPD. Then any deformity. Before that, one is pigeon shaped or pectus carinum, okay, the opposite of that pectus excavatum. So where there the sternum gets depressed, okay, pressed inside, okay. Then scoliosis, okay. Scoliosis, what happens? Lateral bending of the vertebral column, okay. Then kyphosis, forward bending of the chest, okay. Then kyphoscoliosis means both, okay. Both scoliosis and kyphosis is present in a single person, okay. Then inspection, can you measure the size in inspection? No. Why not?
You are not allowed to touch.
We only see, we only observe, okay. Then
Rhythm and
first is rate. So how will you measure the rate?
how many times he is breathing.
How? Huh? Yes. So our field of vision should be at the level of the chest. Okay, then we'll be counting this. Where we'll be seeing his abdomen. Okay, whether it's raising or coming down. Okay, we'll be counting till 1 minute. So what is the normal?
12 to 16.
Okay, in some books it is written 12 to 16. In some books it is written 12 to 20. Okay, so if it is more than 20, this is known as tachypnea. Less than 12, bradypnea. Okay, so this is rate. Then comes rhythm. Rhythm, what will you see? The rhythm is regular or irregular. Okay, suppose he's taking sometime too fast, sometime too slow. Then rate, rhythm, then type of breathing. So as he is a male, his type will be abdominothoracic. In case of female, why? Chest is inclined, okay, and thus the diameter is also less, okay. So the diaphragm, it is 9% less, okay, approximately 9% less. So in females it is thoracoabdominal, okay. So the ribs and the intercostal muscles helps in dual functioning, okay. So in females, like for pregnancies, okay, for any gaseous dimension, okay, or the exchange, okay. So it is functioning dual function, okay, for females. And in case of male, it is the diaphragm, it is more functioning, okay. So it is only taking care of the chest, the lungs, okay. Then anything more in inspection? Apical impulse. So what is that? Okay, apex of the heart, it might be visible from outside, like in cases of malnourished person, okay. If his subcutaneous fat content is less, if he is a skinny person, or in case of increased size of the heart, cardiomegaly, okay. Then yes, scar marks, okay, you have to see any swelling, okay, any visible veins in the chest, okay. Then symmetry, yes, when he'll be inhaling and exhaling, you have to see that both the chest is rising properly or not, okay. Symmetry of the chest. Then inspection, anything? Huh? Yes, accessory muscles. What is accessory muscles? So accessory muscles are those muscles
Help in breathing.
helping breathing. So which is the muscle is helping in our breathing, normal respiration? Diaphragm. So accessory muscles are those muscles which are not helping in primary respiration. Okay. Suppose he'll be having difficulty in breathing, he'll be taking help of the surrounding muscles. Okay. So if he's in air hunger, then his muscles will be acting more. Okay. What are those muscles? Okay. Then scalenus, anterior, medial, and posterior. Then trapezius. Then rhomboides, pectoralis. Yes, chest muscles. How can you miss those? Major and minor. Okay. Then anything? Okay. Then we'll go for palpation. So how will you palpate? Show me. Show me how will you palpate. So when you will examine a respiratory case, the patient should be in a sitting position. Sitting position. Sitting position.
You have to use up 3 fingers. One finger.
Which fingers and where?
The middle finger we have to keep in the suprasternal notch.
You will keep the middle finger on the sternal notch to palpate the trachea. Is it? Yeah? Is it like this? How will you track the trachea? Will you trace it? Huh? You will be using your, this is ring and index finger. Where will you be placing those fingers?
In the joint, in the clavicle.
What is that joint known as? Sternoclavicular joint. Okay. Place it there. And then where is the, this is one joint. So this finger. Then where is the other joint? No joint. You cannot find? This is one joint here. See? And this is one joint here. This there. So you are not practicing. It shows. Okay? When you will be doing it repeatedly, within one go or in two go, you will be able to find that space. यहाँ पे दिखाया था. Where did I show? I can see from here. You are not being palpating it. First place those same fingers there. First find that point, then go for tracing. Tracing you can do. But to locate that joint, let me see. So this is the joint. See this point, and the bone is one bone is here. See. Now place those two fingers. Okay. Then from above downwards, like this, you will feel the tracheal rings. Okay, you will come from above to the sternal notch and see whether the trachea is centrally placed or slightly shifted towards the right. So how will you know whether it's deviated or in place?
With the fingers, with the movement of my fingers, I can see the trachea.
So that muscle which I told, that muscle will help you. That muscle will guide you. How it will guide?
Our finger will firstly deviate, and other thing is
no. You know it?
No, I don't know. But
you know it?
कैसे करना है?
How will you know whether the trachea shifted to any of the sides?
Right side shifted.
शिफ्ट होता है.
रहता है.
What is shift होता है? What is हो जाता है?
I'm not.
This is a practical class. You have to find it practically. You know or you don't? You don't. So how will you find it? So normally when we place these two fingers, okay, in the clavicular or the sternal part, okay, of the angle, then we have to trace it like this, okay, and it will come in the sternal notch, okay. Normally it will be in the notch, and there will be a space between this sternocleidomastoid muscle, okay. There will be a space. You can feel the space. So if the space is diminished, okay, if you cannot find the space, this will tell you that it is shifted towards that space or towards that side. Normally there is a space, okay. If you can't feel the space, if it is decreased, that time you will say that the trachea is shifted towards that side, okay, whether it is in right or there is the left. Then what is the next thing?
Chest.
How will you palpate the chest? How will you palpate? Suppose he was having complaint of chest pain, okay. So in that particular point, you have to press it, okay. Normally you have to press it, okay. If it was on the left side, okay. You have to see whether his expression changes or not, okay, with your pressing, okay, with your palpation. So if his expression changes, that means he is having pain locally, okay, in that angle, okay. Since you were there in the last class, one point was there, na, pleural rub. Have you heard the term pleural rub? Okay, so I'll be telling you. So in pleural rub, what happens? There is inflammation of the pleura. It is known as pleuritis. Okay. So if he is having pleuritis, so we'll tell the patient, because first we'll palpate. If it is locally, then we can suspect that it might be a case of muscles or a bony origin. Okay, the pain started from the musculoskeletal, okay, or from the intercostal spaces. So if it is not, then we'll tell the patient to take a deep breath like this, okay. So when he will be taking the deep breath, if the pain is from the pleura, he will feel a sharp pain. If it is in the left side, from the left. If it is in the right side, from the right. Okay, you can differentiate, you can exclude these two findings, okay. If the origin is from the musculoskeletal or directly coming from the pleura. So in tenderness we will feel it, okay. If it is not, then good, okay. Then tenderness absent, and if it is there, then which part it is present, okay. This is for palpation. Then anything more nahi kichu nahi?
Apex beat.
Apex beat. How will you find the apex beat? So how will you identify the fifth intercostal space?
So in this sternal angle, there is the first.
So first find the angle. Let me see, you can find it or not, or just only memorizing it. So in your medical field, you have to pass both theoretical as well as in practical also, okay. Single passing in any of the theory or in the practical will not help you, okay. You have to be practical also. Where is the notch? Find the notch first. Okay, then you have to go downwards, okay, down, little slowly, not fast. Slowly come down. How will be the sternal angle? Groove, okay, transverse groove will be present. Found it? Let me see. Where is the sternal notch? This one. Okay, this is sternal notch. So I am coming down, I am tracing it. Then I'll feel the groove. So normally it will be like a groove, okay, transverse, horizontal. So here what will happen? The secondary will come and attach. So first of all you need to know the parts. So what are the parts? Manifestation, body and the xiphoid process. Okay. So here what will happen? The second bone will come and attach. Okay. Suppose yes, he is like an obese. Okay. So you are not being able to find it properly. Okay. So this is the second rib. Okay. It is not being palpable easily. Okay. So if this comes and joins here, so if this is the second rib, then which is the first position?
Radial.
Means first intercostal space.
First interpersonal space.
If this, yes. So between second and first rib. Okay. And what is the next? Between
Second, third.
And then
Third intercostal.
Third, first.
then
Fourth.
then fifth. So if this is fifth, then
Mid-clavicular.
which is the mid clavicular line?
Clavicle tip.
Okay, then it is coming here. Okay, fine. Then where will be the location? Anything more precise? You want
Medial,
Yes.
medial side.
middle? It is middle to the sternum, at least 1 to 2 centimeters. So that is the point where you get the apex beat. So how will you palpate it?
First, we will keep our palm.
বলে গেছিস absently. How will you palpate? Which is the most sensitive part of our palm? Fingertips. Okay. And this. What is this part known as? Thenar. Okay, thenar. You know thenar, hypothenar parts of the palms. Okay, the thenar part. Okay, the tips and the thenar are the most sensitive part. So, in some books it is written. You can confirm with your ulnar border. Okay, but it is not like it varies from books to books. Okay, so as it is the tips and the thenar part, we will just put our palm. Okay, in the fifth intercostal space. Okay, in the mid axillary line, 1 to 2 centimeters medial to the sternum. Okay, we'll just keep it and try to feel the beat. Okay, if the beat is present, then apex beat present. Okay, then anything more? Vocal.
Vibrating symbol.
Yes. How will you?
Ask the patient to repeat one.
111 999 or ram ram ram. Okay, so then
Check what the
how okay, you can use the ulnar also, you can use the palm also, nothing wrong in that. Okay, so in some books it is written this way and some books it is written in that way. So do it. How will you do?
111.
First we have to see in the supraclavicular. Okay,
111.
so if to compare in the both sides.
111. 111.
So we have to do this in both the
Side.
sides, anterior and the posterior. In anterior, what are the sides? Supraclavicular, then infraclavicular, then mammary, then inframammary. In posteriorly, how will you see? So when you will be going in the posterior side, you have to tell the patient to cross his hands. Okay, this will expose the back. Then what are the sides? First is the suprascapular, then the interscapular, then the infrascapular. Okay. Anything more in palpation?
Size of chest.
Yeah. So that time you have noticed the shape. Now you have to measure the size. So how will you measure the size? Measure the size. Can you measure like this?
No. From
Measuring tape. Measuring tape. We'll come to that. Okay. You have to measure it. So how will you measure? We'll tell the patient to. We'll circle it. Okay.
on the tent
On the chest. Okay. Then we'll tell the patient to
is inspire.
exhale first. Okay. Then from the exhale, we have to tell the patient to inhale. Okay. And the chest will expand. Maximum expansion. Then we have to subtract. Okay. From the inspiration to the expiration. So normally it is
5 to 7.
4 to 8 centimeters. Okay. So we have to find in this way. Okay. Then shape or the symmetry. You said in the symmetry. In inspection we have seen. Okay. It was good. But in practical, in palpation, how will you see? How? Show. दिखाओ कैसे?
Just expose.
Can you expose, sir? Hold on. Sitting. Okay.
These are hands a little below the hips. Here, the joint or thumb, so that there is a space in between.
Then
Then we'll tell him to inhale.
tell him.
We will see if it is there.
So your hands will be your thumb fingers will be going away or outwards. Okay. So during inhalation it will get outwards. Okay. During expansion and during relaxation it will come back to its position. Okay. Then it will touch. Okay. So how will you know whether any deformity is there or any of the side? Yes. Suppose if the deformity or the pathology is in his right side, which is not letting him to expand properly. So, yes, it will be in the position. Okay, the unaffected side will go away and will come back, or there will be a little movement in his right side. Okay, if the left side is affected, no movement in the left side, or little movement. Okay, the right side will go away and will come back. Okay, this way we will know the symmetry. Okay, measurement only you can do with the tape. Anything more in palpation? No. Okay, then we'll go for percussion. So how will you percuss? Yes, sir. You tell in front of examiner, sir. How?
The flex and the flexing with the fingers.
So what are the steps or in the procedure? How will you do a proper percussion?
Twist and the elbow should be horizontal.
Okay. And the movement should be from the wrist. And we'll be using, if I'm a right-handed person, the middle finger or the index finger, okay, of this hand. And this will be known as flexor. And the non-dominant hand, I'll be placing it where? In the intercostal spaces. What will be the direction? Horizontal to the diaphragm. Then fix, firm. Then the rest two fingers, the index and the ring finger, should be separated. Okay. Then we'll start percussing. So what is the fashion? It should be in a particular rhythm, not too fast, not too slow, and the height should be 2 to 3 centimeters. So if you tell this, okay, the exact procedure, okay. If you can tell this, the examiner will know that you know it. Okay. If you go and tell like this, okay, then he will think that she or he has seen. He was present at the back. She has only seen it, and she is showing this. Exactly, she doesn't know. Okay. So as a medical student, you should know. So show me. So is it possible? The wrist and the elbows in an horizontal direction, and the same plane. Is it possible to place? No. So the proper position is in sitting position. So when it will be in sitting position, you can do it, na? You can do it. So in examiner, can you sit? So you have to tell this also. The proper position for this to
Sitting position.
for this to do or show, we should be in a sitting position, but I cannot sit as I am a student. Then you start, okay? Then the examiner will know, yes, she knows it. So how will you start? So always you should be in the right side. I am in the right side, na? That is why I am in the right side. I can stand that side also. So it should be in, respiratory examination should be in. Yes. Huh?
सर ये तो मेरे में होगा ही नहीं।
दिखाओ आना चाहिए. Every patient is not same, okay? So you might get a same patient, okay, same type of patient. So you have to practice it. Then only you will be able to do, okay?
Index
Your two fingers are fixed or? Huh? So before going into the procedure, just have those process or steps in mind, okay? Okay? If you can tell, then good. Okay, before performing it, again you try to remind it once, okay? So what will be the position of the fingers? It should be in the intercostal space, okay? This finger is known as fleximeter, okay? So it should be horizontally or parallel to the diaphragm. So place it, okay? What about the rest of fingers? It will be separated. Yes. Separate those. It should be there. Don't remove it. It should be there. It should be separated. Okay. Then, yes. Where will be tapping? In the bone, in the bony part. Yes. Not too fast, not too slow. In a rhythm. From 2 to 3 centimeters above. Okay. Okay. So this way you will percuss from where? Where to where? Both anteriorly as well as posteriorly, okay? In whole the spaces, okay? It will start from first intercostal space, okay? All the spaces, okay? Similar fashion, okay? Then as well as in the posteriorly. What are those spaces? Posteriorly, suprascapular, then interscapular, then infrascapular. Okay. So you have to percuss in those point also. So what is the normal sound we hear? Resonating. And any other sound?
Dull.
Dull sound. Dull sound in case of?
Hard organs.
Huh?
organs.
Organs. Okay. And solid organs, okay? Then resonating in case of airs, okay? If it is present in the lungs, okay? So what are the conditions when the trachea is shifted towards the affected side? What are the conditions when the trachea is shifted away from the affected side? Like?
It is fluid filled, then it will
No.
shift to
Away. Like? Pleural effusion and
collapse of lung, then it will shift to
No, first tell the conditions when it is shifted away from the affected side. Okay? Suppose this part is affected, the trachea will be shifted away. So in case of, you said pleural effusion 1, and the second one is pneumothorax. Okay. Then what are the conditions when it will be shifted towards the affected side? Collapse of lung. Then Fibrosis. Okay. So what are the conditions when the vocal parameters will be increased?
Pneumonia. Pneumonia.
One is like in cases of cavity formation, okay, or consolidation, okay. They are the parameters or the contraction will be increased. When it will be decreased,
Fluid. Pneumothorax obstruction.
so when it will be decreased, okay, you always try to find out like if there is an, so normally the contraction is happening why, okay, when he is making the sound it is traveling from the tracts, okay, the trachea, the tracheobronchial tree, okay, the conducting zone, okay, like the alveolar ducts, okay, then it is the transmission is happening through the parenchyma, okay, then to the pleural fluid, okay, then to the chest of the thoracic cavity, then only we are able to hear. So any abnormality or any pathology which is obstructing the transmission, okay, like any air which is separating the lung from the chest wall, any fluid or pus, this will obstruct, okay. So if there is like what to say, pneumothorax or collapse of the lung, so there is more air, so this is obstructing the transmission, okay. And in case of fluid like pleural effusion or pulmonary edema, that time the sound will be less, okay. So we are in percussion. Anything more in percussion? So which is the first dullness you hear in the right side of the patient?
Liver.
6 intercostal due to
Liver.
upper part of liver. Then the after 6th, 8th intercostal square, mid axillary line. So you have to know the anterior, middle and posterior axillary line. So how will you know? So you will tell the patient to move sideways or lateral view, okay. So the anterior part of the axilla will be anterior and the posterior part of the axilla will be the posterior and the middle will be mid axillary line, okay. Simple. Then 10 to space, okay. So this is the margins of the lung, okay. Then anything more in percussion? You want to add anything? No. Then we'll go to auscultation, okay. In auscultation,
The breathing sounds.
breathing sounds of bronchial and vascular and bronchial.
so bronchial sound where you hear?
Bronchial sound.
Bronchus. And vesicular in parenchyma, okay. So do you know the difference between a bronchial and vesicular sound? It is loud and harsh, and vesicular it is soft and low, okay. So do you know the difference? Have you heard the sound before? नहीं सुना है? पहले सुना है कि नहीं? Do you have the stethoscope? Can you bring for her? Do you know?
Yes.
So, what is the difference?
Here you can only
Wear it?
hear inhaling sound, not exhaling sound, because it's absent. But here there is a difference between both, and here you can listen both sound. And here it is a bit harsh, and here it is a bit soft.
It is not absent, it is present.
Present, but it's very less. Yes.
Which is less?
Exhaling sound is less.
So, what are the parts of the stethoscope? Okay, then how will you put it? How will you wear it? Okay, it should be towards the middle. Okay, towards the eustachian tube. Okay, then wear it. Hear the sounds. First, see this on or off. Okay, so where will you hear the bronchial sounds? In the bronchus. Which is the bronchus? So it is best audible when we tell the patient to breathe from his mouth. So you have to tell the patient to breathe from his mouth without making any noise. Okay. This is the bronchial sound. What about vesicular sound? Any difference in the sound? And you hear here, na? Where you going the lower lobes? You hear in the upper lobes? You hear in the upper lobes. This is the upper lobe. So, what are the parts of the lung? There are divisions, na? There are divisions of the lung. Upper lobe, then lower lobe. Okay. Then middle lobe is also there. So in the upper lobe you hear. You have to hear in the upper lobe. So no. Again. So when you are hearing, you should be hearing from both the sides for comparison. Okay. Any difference in the sound? Same sound in both the sides. What about the bronchial sound? Loud. So there is a difference. So now you can differentiate, na? Okay. Yes, bronchial sound. This is the bronchus. Okay. Okay, from here till here it is the bronchus. Okay. Then what is vocal resonance? Okay, so what is that? In the same way, you need to tell the patient what are those words or the numbers. So, what are those numbers?
111999.
So, tell him and see. And here. Okay. So she is now getting oriented. Okay. So where to stand? Okay. She is not standing there and just saying. Okay. So now you people are coming in track, little by little. Okay. Why she is telling to expose his shirt? Wait, I am not asking you. Why she is telling to expose his shirt? Any reason? No reason. Simply. Why are you asking simply? Any reason is there? It may be a false sound. Okay. I mean artificial sound. Okay. Not coming from the lungs. Okay. So first, yes. So what will do about the heads?
1111.
Huh? Madam, what can you do? Can you do anything for the hairs? Okay. So what are from where you will start? Again from the supraclavicular. Okay. Then infra. Then mammary. Then inframammary. And again from the posterior also. So what will be the position of the? Position of the hands. You have to cross his hands. Okay. Then suprascapular, interscapular, infrascapular. Okay. So in the same way, where you found the vocal fremitus as well. So in these cases also the vocal resonance will be increased or decreased, okay, according to them. Okay, so anything in more in auscultation? Okay. Okay, now we will go to the abnormal sounds or the adventitious sound. So what was the adventitious sound? Can you tell, sir? Not taken. So what are those adventitious sound? Tell me. Stridor. So we will come from above to downwards, okay, in anatomical position, okay, or anatomical level. So what are those sides and what are those sounds originating from that sides? Can you tell one by one? Okay. First is the trachea or the epiglottis. So what is the sound? Stridor. Oh, how does the sound? It is loud in intensity. Then it will be heard from distance. Okay, when the patient will be coming from the door, you can hear it. So any importance of this sound? It's like in anaphylaxis. Okay, there will be inflammation of the larynx of the trachea, or sorry, the epiglottis. Okay, so this must be handled by a senior consultant. Okay, this is a medical emergency and life-saving medication should be given as soon as possible. Okay, it should be diagnosed. Any other condition where it can come? So in any obstruction, like in case of children's, okay, suppose a coin went inside, okay, that time also it is an emergency. Okay, then what is the next level and next sound? Okay, or the tracheobronchial tree. Okay, you tell that it is originated from the tracheobronchial tree. What is the sound? Bronchi. It will be, that sound will be inspiratory. Then bronchi is expiratory. So it will be originating from the tracheobronchial tree. Okay, then it will be low in intensity, it will be hard in expiration, and it will be continuous. Okay, first one will also be continuous, this one also will be continuous. The next sound, wheeze. So how will we hear? But musical sound. Okay, it will be musical sound. It is also no. It will be expiratory, but it will be from bronchioles. Okay, we are descending now. We are coming from above, then we are going down. Okay, it will originate from bronchioles. So in cases of asthma or COPDs, okay, and that bronchi in case of bronchitis. Okay, so this will also be expiratory. It can also come in inspiration as well as expiration, and it will be continuous. Okay, then crepitation. Okay. What is, can you tell what is crepitation? You? No. Tell. It is like a small explosive burst. So it will be like a bubbling sound or a clicking sound. Okay. So it is non-continuous. Then it can be low or high. Okay, the sounds which are coming from the above, okay, like from the upper respiratory, it will be coarse. Okay, and in case of small airways, it will be fine. Okay, so the coarse will be low, the fine will be high in intensity. Okay, then no anything more in crepitation? It will be heard in base of the lung, and it will be heard in which type of the respiration? Inspiratory. So it is non-continuous. Okay, then so it will be heard in any condition. Can you tell in any conditions? Tuberculosis, then pneumonia, then okay, proliferation. Okay, but in pulmonary edema also. Okay, in pulmonary edema. Then what is the next sound? Pleural rub. Okay. What is that sound? Okay. So it will be like a rubbing or frictioning sound. Okay. So Anything you want to add in pleural rub? It is inspiratory. Okay, then anything? It is also non-continuous. Okay, it is happening due to frictioning. Okay, with the two pleurals, the parietal and the visceral. Okay, it is known as pleuritis, inflammation of the pleura. Okay, so intensity will be loud. Okay, why it is loud? Because it is more closer to the walls. Okay, the chest. Then low also. Okay, then yes. So this sound, why she was telling him to expose his chest, okay, to open his shirt. Okay, why? First result, why? Yes, because of that sound. Okay, the sound is pleural rub. Okay, so when there will be clothings between the chest of the patient and between your stethoscope, it might give a false impression. Okay, when you will be moving the stethoscope from here and there, suppose when he's breathing, the stethoscope might move. Okay, so this might cause the same sound. Okay, then you will be in doubt whether it is coming from actually from the pleura or from the shirt. Okay, one more thing that is the because of the hairs. Okay, this is also given friction. Okay, understood? Clear? So you want a revision, quick revision, or quick revision? How many are with the quick revision? You are there. You want a quick revision? You?
3 times.
What about you? Quick revision. You? No? Yes. What about you?
I remember most things.
Okay, so you are benefited. Most benefited or what?
Yes.
He is the most benefited. What about you? You want or you want? You don't want. Okay. So the majority is in the quick revision group. So let's.
Can we sit and do the quick revision?
Can
we sit and do the quick?
Yeah, you can sit. If you are having problem, you can sit.
So grades according to the order. And then second complaint was coughing. So for coughing also they will take the history like for how many days he was coughing, what is the smell, odor, the amount of cough.
Okay.
Then for shortness of breath also same thing, aggravating and relieving factors.
Okay.
How many days?
Then
history of past illness. We will ask that if he has faced these problems before also, and if he has taken any treatment, if he is facing from any other disease, if he is taking any medication,
okay. Then
any surgery or something is undergone.
okay. Then
Then we will take the drug history if he is allergic to any drugs or
Okay.
if he has taken past illness.
this is past illness. Then
Personal history. In personal history, first we will ask about the appetite.
family history have taken.
After
Okay. Tell.
family history, we will ask if there is any genetic disease that family members are suffering. Then in personal history, we will ask about his appetite. Then if the diet that he's taking, veg or non-veg. Then the BMI. Then about the defecation. Then the urination. The sleep cycles.
Then anything?
Previously, if he ever
Anything more in personal?
If he's using any drugs or
Addiction.
smoking addiction.
Then about his and anything? Physical activity?
Yeah, physical activity.
Okay. Okay. Then
Then we will take the social history, how his relations are with his neighbors, his travel history, then if he has any pets,
then
the socioeconomic history, how much he is earning,
okay. Then
monthly income.
okay. Then
Then occupational is
okay.
how much he's working, how many hours.
Yes. Okay. Okay. Now next you come. So what do you ask after history?
The history, go to the general physical
Hmm.
Here we observe the general appearance of the patient. We check the pallor, pallor in the palpable.
Okay. You just say the points.
Sinuses.
Hmm.
Lymphadenopathy.
Hmm.
Clubbing.
Hmm.
Build of the patient. Voice. Breathlessness. Checking the fingertips. Finger for nicotine stains. Finger, teeth, lips.
Then anything more you want to add?
It is a respiratory examination, so we have to add shape and size.
Signs.
Size.
GP.
Flapping tremors.
Yes. Flapping tremors.